If we look at this slide that shows mechanism of action of inotropes, it's showing you first and foremost a cardiac myocyte. So not a nodal cell here, but a muscle cell. And as you look at the muscle cell, I would encourage you to look at the bottom first, the beta-1 receptor. As I'm looking at the beta-1 receptor, a drug like dobutamine would bind to this beta-1 receptor and stimulate it. And through the actual GS coupling of this receptor, I would then expect that adenyl cyclase would be stimulated through the GS protein so that cyclic AMP would be increased in this cell. Cyclic AMP will stimulate protein kinase A and in turn literally phosphorylate again ion channels as targets. That phosphorylation of the calcium channel, here ligand dependent on the levels of cyclic AMP and beta-1 stimulation, result in its opening so that now calcium can flush into this cell. As calcium flushes into this cell, any physiology book will always remind you the strength of contractility of a muscle is directly proportional to intracellular calcium concentration. So this increased calcium in turn allows the cell to have a better contractility. Now, in between, let's not forget that calcium is actually packaged in the sarcoplasmic reticulum, such as thanks to pumps, such as the calcium proton antiport, so that indeed it's during depolarization of a muscle that the calcium would be released, relieving the actin-myosin from the troponin-tropomyosin interaction so that the two filaments can slide against each other and contract the actual cell. Well, net effect of dobutamine through beta-1 stimulation is to raise intracellular calcium. Why can't we just do this chronically in any of our patients? Well, this is why. Beta receptors can rapidly desensitize. And if they rapidly desensitize, the use of beta-1 agonists beyond acute management of CHF is bound to fail. So because of this, we need to work differently. We need to avoid that beta-1 receptor that desensitizes so quickly. Historically, then came the drugs enamrenone and milrinone on the right of your diagram. These drugs are phosphodiesterase inhibitors. They're a great idea. Molecular-wise, notice that then they're bypassing that receptor system and immediately working on the signal transduction. However, they work similarly to dobutamine, just from within the cell, blocking phosphodiesterases. Really, if you want to achieve increased contractility without using the beta-1 system that the body of that patient might have been using for years prior to actual diagnosis, well, then you need to use a drug that works with toxicology in mind, much more than pharmacology. And this is the drug digoxin on the top left of your diagram. What should be the concentration of calcium inside a cardiac cell? You remember that it's in the fraction of micromoles, such as 0.1 micromolar. And you contrast this to outside a cell, where it's going to be in the millimolar range. You now have literally a 10,000-fold ratio between extracellular and intracellular calcium, the largest gradient that exists out there for any of our ions. As I'm looking at this then, it's always going to be tough to push calcium outside of a cell. As a matter of fact, to push calcium outside of a cell is a secondary active transport. Follow me. As calcium is moved outside of a cell, it allows sodium to come in. This pump, which we call sodium-calcium exchanger pump, derives its energy to force calcium against its concentration gradient thanks to the sodium concentration gradient. And who actually imparted that sodium concentration gradient? Well, it is the sodium-potassium ATPase pump. So is ATP required in the sodium-calcium exchange? It sure is, although it is indirectly used because the ATP is actually burned by sodium-potassium ATPase. This is what we call in physiology a secondary active transport. Calcium depends on the sodium gradient to be pushed out. What digoxin will do to this system is actually effectively block sodium-potassium ATPase. Digoxin, as a matter of fact, competes with potassium for binding to the pump. And as it competes with potassium, it will actually sit on the spot of the pump where potassium would enter and blocks the actual pump. Hey, first result from this. what should happen to sodium inside the cardiac cell? I hope you're telling me the first point is that sodium is staying inside the cell. This causes a big clinical significance, which is depolarization of this muscle. As you depolarize a muscle, let's not forget that this brings it closer to threshold and increases the risk of arrhythmias. Arrhythmias of muscles might be life-threatening ventricular arrhythmias. However, let's go one step beyond. And one step beyond would be the idea now that if sodium is increased in, there's less gradient to push calcium out. And indeed, the secondary active transport of calcium is also going to become defective, with calcium now increasing inside that cell. So essentially, with digoxin blocking the pump from the outside face of it, you end up with increased calcium in the cell and therefore increased contractility, or what we call positive inotropy. It is this positive inotropy that will actually increase contractility of even the most diseased heart muscle. Digoxin will always increase contractility of a heart, and digoxin has remained literally one of the best drugs we have to increase contractility. Let's find this in our text. Digoxin is said to have two types of pharmacology. One type is what we call the direct effect, which is what we've described together. It is the inhibition of the cardiac sodium-potassium ATPase, resulting in high intracellular sodium. Let's not forget this means potential for depolarization, and in turn the decreased sodium-calcium exchange. Well, result from this, increase intracellular calcium, resulting, if you want, directly at increasing the contractile force. As you take digoxin, you certainly are not injecting it inside your heart. You take it orally, and that is if you take it chronically, or you might take it parenterally. Whatever the case might be, digoxin is going to do the same sodium-potassium ATPase inhibition throughout the body. So here's what we call the indirect effect of the drug. It is the mere fact that this drug is, again, an ANS type of agent. Yeah, like all drugs that we've seen so far, there's always an ANS story. And here is the ANS story. If you're in a nerve terminal, and let me just give you a little diagram for this. If you want to insert it in the margin of your book, it would be a good idea. Here is a nerve terminal, and here's the vesicle to release neurotransmitters. Neurotransmitters such as norepinephrine, if your sympathetic autonomic nervous system, or neurotransmitters such as acetylcholine, if you were in the parasympathetic. Let's not forget that anatomically sympathetic is really primary for muscle innervation, particularly for the ventricles, which I'm just going to call V here for the sake of space. And with acetylcholine, we have primarily a nodal innervation, particularly the pacemaker activity of parasympathetic. How does a neurotransmitter get released? Well, the first thing that is required is to have depolarization. This depolarization then in turn allows calcium entry through voltage-dependent ion channels in order to trigger the actual release. So here is my sodium-potassium ATPase pump, trying to force sodium back out of a cell and trying to bring potassium back into that cell. And here is, of course, my digoxin blocking this pump. As digoxin blocks the pump and sodium stays in, what can you now tell me about the depolarizing effect of digoxin on a nerve terminal? I'm sure you're realizing clearly that depolarization is going to occur. This will be followed by calcium entry, which in turn will result in neurotransmitter release. Well, this combined sympathetic and vagal effect of digoxin is what we call the indirect effect of digoxin in the heart. Let's go back to our notes. As we look at these notes, it is said right here that the indirect effect of inhibition of neuronal sodium-potassium ATPase results in increased vagal activity. And you will, of course, read on your notes, it is absent on this slide, unfortunately, that it should also say increase sympathetic activity. Now, what are these two things going to combine to do to a CHF patient? Increased vagal activity will decrease the heart rate. If you decrease the heart rate, would you have more time for diastolic filling? Of course you would. You would improve filling. And if you improve filling, Starling told us Very much so that the more I fill the heart, the more it contracts back and improves its cardiac output. So here we go, just from vagoactivity, an improvement in the cardiac output. How about the increased sympathetic activity, not to be forgotten? Increased sympathetic activity has a direct inotropic effect through those beta-1 receptors and norepi. Now I know some of you are thinking, wait, I thought they were desensitized. Well, certainly this is not the primary mechanism of action of digoxin, but it is obviously one that will help very much in the CHF. When I'm looking at those direct and indirect effects, let's not forget that digoxin will also block sodium pump in other tissues and organs of the body, hence a number of side effects. So let's look a little bit at its pharmacokinetic. As I'm looking at the pharmacokinetic of this drug, I see my first clinical problem. This is a drug that has a fairly long half-life. A long half-life does mean that it takes 4 to 5 of these half-lives to reach the steady state. And in situations that are emergent, such as a drop in cardiac output, it would probably require loading doses of digoxin. This is actually what we refer to as digitalizing a patient. And giving loading doses of a drug that has the potential for arrhythmia might very well be a problem. That long half-life comes from primarily high tissue protein binding. In effect, you can at least name me one. Sodium potassium ATPase, which is in tissues. And you know that drugs that have a high tissue protein binding have a large volume of distribution, which always opens the door for other drugs to displace this digoxin from tissue protein binding, in which case increasing the free fraction would increase the toxicity. Do you remember two drugs that we've mentioned in the previous cardiac chapters? If you're saying quinidine and verapamil, which are noted in your syllabus, then you know that these drug interactions have been classic points on the exam. Now another point, not only this is a drug that has a long half-life, but you also know that you need to know about the clearance of such a drug. Here's a point of relevance. This is a drug that is primarily renally cleared. Because digoxin is renally cleared, you need to worry in renal impairment. Here the relevance of such a statement is to remember that a patient with congestive heart failure has a poor glomerular function, and because of this it is likely that the decreased clearance of digoxin will further increase its half-life, requiring then longer time to reach those steady states and potentially adding on more drug in that patient's body as we chronically dose them with digoxin, possibly further increasing the risk of toxicity. Digoxin's primary use is in congestive heart failure, both acute and chronic management. However, because of the strong vago effect of digoxin, this indirect activity of increasing acetylcholine release in SA and AV node, this is a drug that also historically has been used for supraventricular tachycardia, simply because of protecting the ventricle from fast atrial beats in patients with those types of arrhythmias. It is quite amusing in a way to think of such a toxic drug being used for arrhythmia management when one of its primary side effects will be to lead to cardiac arrhythmias themselves. Now, in recognition of the toxicity to digoxin, well, besides doing careful therapeutic drug monitoring to maintain our patients in between the correct therapeutic range, it is pretty neat to know that the very first side effects of this digoxin would be associated with gastrointestinal type of disturbances. A patient feeling a little bit nauseated, not too good, potentially having some GI problems such as some diarrhea. And then some EKG changes would already show you that you are in the process of approaching potentially life-threatening arrhythmias. Beyond the GI, a little later in the intoxication, when you have higher concentration in your body, central nervous system is going to start showing all kind of abnormalities. After all, let's remember that digoxin, by blocking sodium potassium ATPase, will result in neurotransmitter release. So disorientation, a patient acting as if he or she were drunk, are very classic of digoxin's toxicity. Visual effects, such as halos around objects, are also reported. I would highlight well those halos around objects, being that this is unusual in an intoxication. Most patients will tend to really refer to us as if they had sunglasses on, or as seeing some orange or yellow halos around objects. Well, always take this point seriously, because any type of cardiac arrhythmia is potential at those higher doses, including life-threatening ventricular arrhythmia. So what would be the management of a toxicity of a patient who's taken too much digoxin? Well, a patient with digoxin intoxication, we can potentially use an antidote. And the antidote, as far as your exam is concerned, are those F-AB antibodies towards digoxin. A little bit as if we were using an immunoglobulin therapy in a patient with an autoimmune disease. The idea being the antibodies are going to bind to the digoxin, preventing the drug from binding to its target on tissues. Otherwise, primarily, the management will be supportive. It is relevant to monitor electrolytes, particularly potassium, and importantly for the arrhythmias, since digoxin depolarizes tissue, a class 1b drug such as the drug lidocaine would be primarily indicated to fight the arrhythmias. Even drugs that we'll see in our next section, such as phenytoin, can be also used in the supportive management of digoxin. As far as drug interaction, any drug that has a potential of causing life-threatening arrhythmia, we need to have an idea what could worsen it. One of our subsequent chapters will deal with diuretics, and diuretics at large are famous for causing hypokalemia, and hypokalemia will have to be a worry of ours. Remember that digoxin and potassium compete with each other for binding to that pump. Meaning simply, if there is hypokalemia, there's easiest access for digoxin to work on the pump, therefore an increased potential for toxicity. Conversely, hyperkalemia would actually minimize the effect of digoxin. This is why potassium has to be very carefully monitored when patients are taking those diuretics for the passive congestion of tissue, such as pulmonary edema, and at the same time as taking the digoxin for their congestive heart failure. Potassium may even be administered in order to maintain normal level. Potassium surely would not be the only electrolyte of relevance. Any increase in calcium, any drop in magnesium would also worsen these toxicities. The final drug interaction. Hopefully last time we mentioned this in our review, the famous effect of quinidine and verapamil displacing from tissue binding site that drug. Otherwise not mentioned in your book, don't forget that any other drug that might have pro-arrhythmic effect would be additive to those of digoxin. For instance, using other sympathomimetic drugs such as dobutamine, such as norepinephrine, epinephrine, any drug that you know could increase contractility and cause tachycardia at the same time, such as beta-1 agonist, would also potentially worsen the risk associated with digoxin. In the margin of your text, there is a note about the famous Wolff-Parkinson-White syndrome. This is a nice point to bring up this type of arrhythmia, being that now we have seen most of the drugs that are used for supraventricular tachycardias. Remember, drugs like class 2, the beta blockers, class 4, the calcium channel blockers, also adenosine for the drug of choice in supraventricular tachycardia that would be non-responding to other drugs. And finally, digoxin in this chapter that is also used for SVTs. In Wolff-Parkinson-White, the patient has an arrhythmia associated with conduction accessory pathways, CAPs. These are actually fast muscle fibers that are healthy fibers that still bridge, as indicated by the big arrow in your diagram, atria to ventricles. It means there are literally two pathways to conduct the electrical activity from the heart. When the action potential starts at the SA node, this action potential now has two routes. The classic route through nodal tissue will follow a slow conduction from SA to AV node, and then from the AV node through the His-Purkinje system, then depolarize the ventricles so that hemodynamics closely follows the electrical activity. Unfortunately, in a patient with WPW, as the SA node fires, there is no way of preventing these action potentials from directly getting to the ventricles. In a slow conduction pathway such as the blue pathway on your diagram now, it is possible to think that the AV node might not yet have been depolarized as the potentials are slowly reaching there, yet the ventricles are already depolarized. And if these are already depolarized and AV node is not yet refractory, electrical activity will now re-enter through the AV node and stimulate further the atrias. As such, in a way, there are two ways of stimulating atria in this patient. The classic SA node, but also the re-entry pathway through the AV node secondary to the conduction from these accessory pathways. It is thought that in embryogenesis there is a failure to actually separate properly all four chambers of the heart, and healthy muscle fibers still bridge directly atria to ventricle. Now, we understand that then the issue would be remove these accessory pathway. As a matter of fact, the best approach would certainly be surgery and to do laser ablation of those pathways. But if we were to use drugs, which often we have to do so, if anything, before surgery, and for some patients we just cannot do the surgery, then we need to block accessory pathways. They're made of fast response fiber, so a class 1 or a class 3 drug would be indicated. In the class 1, let's not choose a class 1b that works in hypoxic tissue. This is not hypoxic tissue whatsoever. And certainly let's not use a class 1c that could cause sudden cardiac death. So rather we'll go for a class 1a, particularly for a drug such as quinidine. Quinidine will also have anti-muscarinic effect. Recall that this is an effect that speeds up conduction in the AV node. And as such, we'll try and make the pathway that is nodal, that is physiological, predominant. At the same time, quinidine will block the action potential by decreasing phase 0 in the fast response fibers in the conduction accessory pathway. You could have used amiodarone or so chronically to do the same job. What you must not do is slow AV nodal conduction. And a point to remember is that classically, this is what we normally do for people with SVTs. So here you have an SVT for which it is not indicated to slow AV nodal conduction. This means do not give digoxin, beta blockers, calcium channel blockers, and adenosine. Simply, it would actually favor the conduction accessory pathway. Use drugs that work in muscle. As to the phosphodiesterase inhibitors we mentioned in our entry diagram in this chapter, enamrenone and milrinone increase cyclic AMP through this enzyme inhibition and do so in both heart muscle and smooth muscle. It is quite interesting to realize that increasing cyclic AMP in heart muscle, as we did with beta-1 stimulation or as we're doing now with phosphodiesterase inhibition, results in increased inotropy, increased contractility. Yet, increasing cyclic AMP in a smooth muscle rather than heart muscle results not in increased contractility but vasodilation. Example, whereas a beta-1 increases heart contractility, a beta-2, which is also GS-coupled, vasodilates. So we'll have to try and understand how come cyclic AMP increase can result in opposite effect in heart and smooth muscle. Well, let's talk about this in our next chapter of angina.